Many like to point out that trans people have always been here, just as many point out that gay people have always been here. Of course, this claim relies on retroactively ascribing labels to dead people who can no longer speak for themselves, often ignoring the cultural factors that might have led women to dress like men or men to be placed into a third gender role. It also relies on ignoring that transitioning has been historically used as a conversion therapy tactic, as the appearance of heterosexuality seemed like a better solution to homosexuality by many groups. The original reason why LGBT included the T is because the T stood for transsexuals, gay men who felt more comfortable portraying themselves as women, but held no misconceptions about the fact that they were not female. Now, the discomfort many feel with their own bodies has led to the creation of a profitable medical field that takes advantage of the cultural pressure to be trans instead of gender nonconforming, to transition instead of question why one feels this way, and has in turn found a willing and ready to pay class of people who will do just about anything to feel better, including unnecessary and invasive surgery with dire consequences. The community itself pressures those who encounter health problems requiring them to stop transitioning to continue, which is quite interesting considering the claim that trans people will have to transition or commit suicide due to the mental health issues dysphoria brings. Those who transition are unable to give informed consent as they are not adequately warned of the consequences transitioning has on their health. Take, for example, the effects of transitioning on women. As a result of hysterectomy or Lupron use, women face a higher risk of osteoporosis. Hysterectomy is linked to a higher risk of dementia. Testosterone also causes uterine and vaginal atrophy, which is rarely talked about and yet is a medical certainty. After a few months to a few years on testosterone, these women's reproductive organs are rotting inside their bodies. No woman on testosterone is exempt from this and can lead to recurrent bacterial infections which lead to kidney infections, which leads to sepsis. 28 studies on the long-term outcomes of medical transition have shown higher rates of suicide, alcoholism, disability, and unchanged or worsened mental health. Men who undergo SRS find their promised neovaginas to be nothing like the organ it was modeled after. Neovaginas can grow hair inside the organ and require dilation to prevent the wound from closing. If kept open, neovaginas made with intestines will smell like intestines. Both trans men and women are sold the lie that their genitals will look exactly like the other sexes, and they are not warned at the pain associated with these surgeries. Additionally, puberty blockers have been sold to parents and teens as a way of harmlessly halting puberty to ensure that the child goes through the correct puberty for their identity. It is seen as a safer and easier way to deal with being trans, as this way one won't have to correct the puberty they went through to mimic the sex they wish to be. The primary drug used is Lupron, though it is used off-label. Lupron has been used for everything from endometriosis to prostate cancer to precocious puberty, and it does almost nothing as prescribers promise. The main effect of Lupron is to eliminate the production of estradiol, one of 3 estrogens we produce. The reason Lupron is used to treat endometriosis, then, is to stop the production of the hormone causing uterine tissue to grow outside of the uterus. Eliminating estradiol inhibits metabolic flexibility, meaning they are less able to respond to a changing environment. An estradiol deficiency causes misshapen and dysfunctional cells all throughout the body, which can lead to symptoms like chronic fatigue, muscle wasting, and autonomic system dysfunction, which affects blood pressure, temperature control, digestion, bladder function, and sexual function. Derangement of mood and perception, immune dysfunction, hyperinflammation, cardiac issues, as well as severe osteoporosis and arthritis. Perhaps most shocking of all is the link between Lupron and lower IQ, among other mental health problems. Recent findings that GnRHs, one of the ingredients in Lupron, increase depression symptoms and slow reaction time in healthy women and reduce long-term spatial memory in sheep. It was found that girls had a mean IQ of 94 as against the mean IQ of 102 for the matched control group. Those who transition young often find themselves faced with the consequences of making a decision that children simply are incapable of comprehending. This may be compounded by the mental health issues that many trans people face, including depression, which can make it difficult to conceptualize the future. How can a 14-year-old consider the consequences of hormones when their prefrontal cortex is not fully developed, when their limbic system prevents them from having adequate impulse control, or considering how their current choices would affect them in the future? And that's, of course, under the implications that these trans kids are actually in charge of their own transition. During a medical torture program called the Inversion Project in the 70s and 80s, the South African government surgically cut off the penis and performed forced sex reassignment surgery on almost 1,000 drafted gay men between 16 to 24 after torturing them for months. They thought if they can't turn them straight, they could at least turn them into women. To this day, many countries in the MENA region view transsexuality as good and homosexuality as bad, because they think that being trans is a cure for homosexuality, and trans people are good gays who accept that being gay is bad and want to change. Meanwhile, Western trans activists still refuse to acknowledge that parents transing children can be homophobic child abuse. Many children who are gender nonconforming, an aspect that has been pathologized into an aspect of being trans, would often desist feeling the need to transition by adulthood. For example, lesbians are 12 to 19 times as likely to display extreme levels of gender nonconforming behavior. Many families see transitioning as a way to make their deviant gay son or daughter into respectable straight people. Take the story of Lily Ebe, the first recipient of GRS. Lily died in 1931 from cardiac arrest from pervasive infections 3 months after Ebe's final surgery of 4, a grotesque attempt at performing a uterus transplant and making a vaginal cavity. Doctors were aware of the impossibility of what they promised Lily, as experiments in the early 1900s illustrated the issues of organ rejection, and transplantation attempts were abandoned by the start of World War I. The first successful transplant of a full internal organ rather than scanned pieces of tissue was not performed until 1954 in the city of Boston, where Dr. Joseph Murray and his team transplanted a kidney between identical twins. Other attempts to transplant human tissue included fashionable treatments marketed to the rich, wherein human or animal ovaries and testicles were transplanted into the wealthy to restore youth. However, the doctors who intended to perform these transplants used these experiments as basis for new theories of human sexuality. They believed that homosexuality was influenced by the sexual glands and their secretions, since sexual behavior could be changed through the application of these newly discovered hormones. Hormonal treatments were thereby immediately used to chemically castrate gay men and lower the libido of both homosexual men and women. In other treatments, sex-typical hormone injections or gonadal implants from heterosexuals were performed on gay people in order to get them to behave normally. The first example of GRS was a callous experiment which led to the death of a desperate patient, and has set the trend for further advancements in the field. Perhaps the worst part of all of this is that the medical field is steadfastly pretending that this is not an experiment. The vast majority of children referred by the Tavistock for hormone blockers continued with their transition once they became eligible at 18, but how they are getting on remains unclear as the clinic did not collect the data, a fact that the High Court judges in the Kira Bell case noted was surprising given the young age of the patient group, the experimental nature of the treatment, and the profound impact that it has. After all, experiments record results, and there is an active effort to prevent recording the outcomes of frankly dangerous prescriptions and treatment. The cost of transition itself can put trans people into further debt and cause a greater sense of sunk costs, preventing trans people from feeling that there is another way out. The cost, too, makes it profitable for experimentation to continue. Because of the cash cow that transitioning provides, it's almost nearly impossible to sue for malpractice. There is no way to hold their doctors accountable for their actions. Cross-sex hormones, which without insurance can cost $100 a month, are intended to be prescribed for the rest of the patient's life. If you've got 100 patients on testosterone, that's $10,000 a month for that hospital. Trans surgeries can range from $6,000 for top surgery to $100,000 for a phalloplasty or vaginoplasty, and the frequent complications arising from these surgeries often see additional changes. Hospitals are underfunded, they need money, and transgenderism is a never-ending stream of money. Because there is no real way to diagnose a patient with being transgender because it's not a physical illness, and because it's incredibly hard to win malpractice cases anyway, there is practically no way for medical practitioners, the hospitals, or its donors to be held accountable. Even the therapy that bridges the gap in the dysphoria to patient pipeline is resistant to asking if any of this is harmful or if it even truly works. Therapy pushes people to transition without further questioning of why they might feel this way, preventing people from undergoing the introspection necessary to treat their dysphoria in a non-surgical manner. There is no other disorder that I can think of where a therapist is there to affirm the client's beliefs, i.e., I am fat and need to starve, I am in pain and need to self-harm to release it, I get a sense of control from beating my partner, my addictions have no effects on my family, I am in fact Jesus, or whatever. The job of the therapist is to explore what these feelings are about and reflect them back to the person in ways that could be helpful. It is a conversation unlike any other, and that judgment must take a back seat to listening. They may feel forever unhappy with their bodies and/or sexual orientation. Therapy is no guarantor of happiness. I don't pretend it's easy for anyone, but the wait and watch approach just seems basically kinder than the rush to puberty blocker to cross-sex hormones to surgery path. This is the consumer-led view of self-creation that is the apex of neoliberal thought, yet strangely embraced by the left. The effects of testosterone on biological females are far more long-term and irreversible than the effects of estrogen on biological males. The do-no-harm approach, therefore, must be the first principle. No one wants to trans the gay away, surely, but affirmative therapy is not actually therapy at all. It is simply a facilitating the transition and therefore another form of conversion therapy. If conversion therapy does not work for gay people and should be banned, then why is it pushing young gay people into treatment they may come to regret later on, deemed transphobic? There is huge category confusion here, and yet the reality is sitting in a chair opposite a sobbing adolescent girl who is full of self-hatred. The true question is, what do we do about this? For one, I believe we must stop talking about gender dysphoria like it's an innate, real thing that exists independent of our culture, which is assigned meaning and value and expectations to our sex bodies. In other words, we must understand that gender dysphoria in turn stems from the discomfort we face with societal gender roles and standards. In turn, gender dysphoria is the label we ascribe to make sense of distress about one's sexed body. This allows for the pathologization of a natural distress of cultural standards that are inherently meant to be uncomfortable for women and for men to benefit from, though men may also be uncomfortable with these roles, which can be added upon if they have same-sex attraction. Instead of pretending this distress is innate and unconnected to societal standards, we must question where it comes from. What conditions gave rise to distress about our sex bodies? Strict and limiting gender roles and expectations assigned to us based upon those sex bodies. As a result, transgenderism is built upon taking the suffering based on just strict gender roles and instead offering another role to step into. Instead of arguing that one can really exist outside of these roles, these boxes if you will, they instead create more boxes or offer to switch. It is better to describe gender dysphoria as distress at one's sex because it is more accurate and invites curiosity toward causes and solutions that don't necessarily lead directly to transition or transgender identification. It allows for the healthy questioning at one's distress in therapy, which can allow for non-medical or surgical treatment. And in the end, I think it's better to wait and see than to force people into experimentation that's going to leave them suffering later on. This, dear viewers, is where we part. I am once again using footage of my trip in Prague, and I hope that you guys enjoy. Please leave your likes, comments, and whatnot below, and I'll see you guys next time. Bye.